Welcome back to the post-lunch session. I hope you all had a good lunch. To start things off, we have a symposium on adult ADHD. It will be chaired by Dr. Dulangi Dahanayaka and Dr. Sumuddu Godavita. Over to you, madam.
Good afternoon, ladies and gentlemen. Welcome to the symposium on adult ADHD. We have two eminent speakers today in this session, Dr. Tilaka Ratnayaka and Dr. Peter Mason. I would like to invite my co-chair, Dr. Dahanayaka, to introduce Dr. Tilaka Ratnayaka.
Thank you. Dr. Tilaka Ratnayaka is a consultant psychiatrist with experience both in Sri Lanka and in the United Kingdom of more than 30 years. He qualified as a doctor from the University of Peradeniya in 1985. He obtained MD in psychiatry from the Postgraduate Institute of Medicine, Colombo, Sri Lanka in 1992 and worked as a consultant psychiatrist in Galle, Mathara, Anuradhapura and Polonnaruwa before migrating to the United Kingdom in 1996. He was involved with many service development projects during his time in Sri Lanka, including initiating the first psychiatric rehabilitation unit in the country. He also worked as a senior lecturer at the Faculty of Medicine, University of Ruhuna, Sri Lanka. He has been an examiner for MRC Psych CASC examination for more than 15 years. His special interest is adult ADHD, and he is involved in developing the service as project lead in Bedford, UK. Over to you, sir.
Thank you very much for the kind introduction, Chair. And good afternoon to everybody. And I'm delighted to be here. And special thanks to Gihan, the President, and Secretary Chamara, and the College Council, giving me this opportunity. Actually, this is the best time to listen to a talk after a fantastic Congress annual dinner yesterday, which went till 1 a.m., and now postprandial, nice rice and curries, if you have ADHD. So the topic, you can see, I am going to do a brief overview, and one of my colleagues, who is a national recognized consultant, Dr. Mason, will talk about his part after my presentation. So why I am presenting this? Because you all know it is several debates about adult ADHD. There were no issues about child ADHD. Any child psychiatrist 100% say, yes, that exists. But when it comes to the adult ADHD, if you ask from an adult psychiatrist, I'm not surprised the audience become 50-50. Actually, if you ask from me 6-7 years ago, which side I am belongs to, I think probably I would be in opposition. But last few years, it made me to shift my own clinical practice to say, yes, that exists. So my talk is to substantiate my understanding and my experience about it. But I don't want any of you to take it in and be open-minded and then decide using your knowledge and your clinical experiences and thinking about your patients. What happened to me was, when I was inpatient consultant, there was a patient, who's a 27-year-old young lady, a psychology student, who came to me with 3 diagnoses: bipolar affective disorder, emotionally unstable personality disorder, and drug misuse, and schizoaffective disorder as well. So I thought this is a bipolar affective disorder because she had depressive episode. She had a massive manic episode. She used illicit drugs, primarily cocaine. And she has lots of reckless behaviors. Bought a car a very expensive car and then got caught high speeding, and also having sex with the strange people, never know who she slept with next day morning. I thought this is a classic manic episode, and also having a depressive episode. Actually, at that time, some of the Sri Lankan trainees were with me, who are consultants now. And then I started treating for bipolar affective disorder, this difficult woman. And I thought this is bipolar affective disorder plus emotionally unstable traits. Then my covering consultant, who is having understanding about ADHD, after seeing said that, Tilak, why don't you think this may be a ADHD rather than anything else? And try ADHD medication. Even I didn't know what ADHD medications, and he suggested to me methylphenidate, which we started. And then, within 2-3 weeks, she became a different woman. And she herself said, after a long time, I'm back to my normal self. I see my normal self. So that is the time I could convince, yes, this should be exist. Then I got the training from Mosley, and also started the project. I have seen more than 200 patients by now. And then I thought, yes, it exists. But same time, I would say that it is undiagnosed, misdiagnosed, overdiagnosed, and all these things happening. That is the confusion. So please don't take anything in. You think yourself and come into the decision. So my clinical experience in favor of ADHD. But what are the evidence? The scientific evidence, of course, is a clear, robust evidence to show that people having child ADHD and then persist into adulthood, 50 to 66%. So that should exist in that sense. And this is a global prevalence, but you can see when you come to the side of Asia, only Australia is there. So there is many non-believers like me. They are in various other countries. Europe and America and North America and those areas, they are interested about the ADHD, has done researches. But you can't see anything in India, Sri Lanka, or Russia, all these places in that area, except Australia. But world understanding is adult ADHD exists, and it is prevalence is 3.4%, and it varies from 1.2 to 7.3%. And also they found it is more common in males than in females, 1.6 to 1. And in our diagnosis, DSM-5, ICD-10, even ICD-11, they recognize adult ADHD as a condition. I don't want to go into the details of the slide, because I would rather like we to have a debate and discussion, and also I would like you to listen to international, the UK, the nationally recognized speaker, Dr. Peter Mason. So, clinical presentation, this is an important slide, because when you read this, there are psychological indicators and behavioral indicators are very much similar to your bipolar affective disorder patients and your EUPD patients and your patients who are chronically using illicit drugs, mainly cocaine. Psychologically, chronic low self-esteem, frustration and feelings of failure, and not living up to one's potential. That is the main thing. We come across people, they are having the capability, they have the intelligence, they have all these things, but they are not performing well. Either they are in the exam, or in their employment, or in their promotion. And also feeling easily overwhelmed with the new situations, like new job, having children, or passing exam or any of these things. So then they are overwhelmed and behave like a kind of having a hypomanic episode. Mood fluctuations throughout the day. That is another thing, where the norm is and the abnormal. There is a very gray area. We know yourself and your friends, some people are having a mood fluctuation. We don't call it as ADHD or bipolar. So it is another gray area, which is normal mood fluctuation and what is abnormal. Actually, when you go to the different countries, if you go to Jamaica, you will see that all are hypomanic. And there are some part of the world, say, I have been to, say, Pakistan. If you go there, you think these people are very distressed and depressed all the time. So that is the difference. It has a big cultural kind of variation. And recurrent depressive presentations that are unresponsive to treatment, that is a crucial word. My patient I described, she was prescribed all sorts of medications, antipsychotics, mood stabilizers, antidepressants, benzodiazepines, everything was given. I'm not exaggerating, but you still keep on admitting and having the behavior. So this depression, people can misdiagnose it as a bipolar affective again as they get the depressive episode. But it is not easy to differentiate. And difficulty getting to sleep, and may complain that they can't switch off. They're always on the go. And behavioral and lifestyle indicators. This might remind yourself sometimes. One point I thought, oh, I have ADHD. Disorganized, lack of forward planning, and bit messy when you go to your bedroom or your study room or where it is. Bit messy, can't keep tidy. And forgetful, miss your appointments, lost things, and being late. And chronic procrastination, because inefficient. They try hard. Sometimes they work hard, but you cannot achieve the goal that you wanted. Poor time management, many of us having to some extent. And start things but get easily distracted. They start a lot of things. This project, that the thing, but they won't complete it. And they easily distracted from that and get into another one. So you can see that it is a bit of a bipolar hypomanic presentation as well. The distraction affecting the education, and as I said, this procrastination, and struggling to complete your goals, whether it is job or your studies or your degrees. And difficulty in maintaining employment. Many of my patients, they are moving from one employment to another because they find difficult to cope with their managers, and they think that they are not satisfied with the job and kept on moving. And use alcohol. More than the alcohol, use illicit drugs, mainly cocaine. I think 60-70% of patients, if they are using illicit drugs, they use cocaine, because cocaine is making them more relaxed. So we can easily misdiagnose it as illicit drug use. And they more involved in criminal offenses like high speeding, accidents, etc. So recognition of adult ADHD is increased prevalence in some populations. You heard Dr. Sullivan's talk in their forensic areas. You can see the people with adult ADHD. And people with epilepsy, mental health conditions, acquired brain injury, history of substance misuse, neurodevelopmental disorders, people with close if somebody has a family history of ADHD. And it's associated with complex neurobiology. There is evidence to say that it exists. There are structural evidence, functional evidence, and chemical evidence. Structural evidence, they have found that it's associated with structural abnormalities such as the gray matter density in the bilateral dorsal attentional network than in adult ADHD people. And also, biochemically, they have found that there is a dopaminergic involvement with the environment factors and serotonergic involvement. Neurochemically, again they found there is an effect on their executive function areas, especially cingulate cortex, prefrontal cortex, caudate nucleus, and cerebellum. And negative impact, if you are not treated with the adult ADHD patients, and they have found robust evidence that it can have an impact on their education and employment, especially family relationship, problems in family relationship, quality of life, their mortality is high, their risk-taking behaviors, criminality, reckless driving, substance the misuse, etc. So there is a clear evidence that if you are untreated, there is a negative impact on their life. And when you come to the diagnosis, it is not just using a rating scale and treating with medication. So you need to involve with the family, you need to do the family coaching and cognitive behavioral therapy, all these. Pharmacological therapy is one of them. And there's a bit of a mix-up with the slides, but it's okay. And they have found that treating adults with ADHD may lead to lots of benefit, especially 100% in their driving performance, and also 90% in their self-esteem, and 80% of social the functioning. So there is a clear benefit of treating patient with adult ADHD. So there is available pharmacological treatment. I understand in here you have methylphenidate and you have atomoxetine. So we have for adults it is indicated long-acting amphetamines, at least dexamphetamine, and also even though it says that it is not licensed, still methylphenidate short-acting is used, but usually what is licensed is methylphenidate long-acting. We use Ritalin XL and Medicanet XL primarily. So actually my 2 slides are missing, and when I was sitting in the audience, I was just Googled adult ADHD in Sri Lanka. And I found there's a very 2 nice comments. There are several comments. One is an article published by child psychiatrist Perra, child psychiatrist who had Hemamali Perra, isn't it? And that it says they have done a study with the parents who are the children who are suffering from child ADHD, and they found there is a significant findings of these adults, parents are having adult ADHD. But in their final summary they said, but unfortunately they cannot treat. They haven't been treated because of the controversy of the diagnosis and treatment. That is one. And the second thing is somebody is making a comment saying that I think I have ADHD, but I went to a psychiatrist and psychiatrist said, no, half of the population having your symptoms and go away. And he was saying that, do you know anybody who has understanding about adult ADHD? So you can see there is a public controversy and professional controversy. And there is I think this is the first presentation I said, this is not the amended, but that's okay. And then I have another slide. How do you do the screening? You don't have the latest updated one, do you? Or you can't do it now. That's fine. No, it's okay, that's fine. It's because we can have a time, 10 minutes for a discussion. And then in the screening, we have VU. There are several scales. But I use DIVA 2 and also self-rating scale. And when you come to the self-rating scales, you need to be very careful because many false positives are there. But when you get the self-rating scales, what I do is I'll send the self-rating scale first. And I get many of them who thinks that they are having ADHD. 90% they say that yes, self-rating scale comes to a cut-off point. But still I don't do the full screening. I have a discussion with them and the family and then see whether whether there is a signs, potential of him or her having adult ADHD, and then only I do the DIVA questionnaire, which take about 1.5 hours. And then decide whether somebody need to be started treatment. And treatment consists of, as I said, pharmacological treatment and psychological treatment and family therapy. So that is what I wanted to give the message about my experience and the evidence that we have for existence of adult ADHD. And then I thought, if audience thinks, yes it is, and it is some area that we need to develop, then of course, is it timely requirement that adult ADHD service project in Sri Lanka is worthwhile? And we can open for a discussion. So as I said, I'm not here to for or against. That is my personal view, but you can have your open mind and think about your own experience. And you can hear from Dr. Mason as well about the comorbidities, because sometimes many comorbidities which I mentioned, we might treat them, but they kept on coming again and again. And some of them end up in prisons. Some of them end up in the centers where for rehabilitation and all, as they are not getting, and we think this as treatment resistant. So all these things can happen. If we find the right diagnosis, then definitely it's more or less 98% stimulant work for patients with adult ADHD. So thank you very much, Chair. And I would like to take any questions because we have 9 minutes, and I would rather like to know your views about it.
So we have a Q&A session at the end of this symposium. Okay. So shall we discuss the questions at the end, sir?
That kind, because I thought that Dr. Mason is joining only at 2:30. If he's ready, I think I would rather like to hand over to Dr. Mason, because I would like you to hear from him.
Thank you very much, sir, for your informative session. We will invite you again for the Q&A session after the next lecture. So let me introduce Dr. Peter Mason. Dr. Mason is a consultant psychiatrist with 30 years of experience working in the NHS. He first started to treat adults with ADHD in 2006 at a time when most people were skeptical about the condition, and from there pioneered the development of adult ADHD services across Wirral, Liverpool, parts of Cheshire and Bolton. In 2018, Dr. Mason took early retirement from the NHS and set up his own private clinic, Dr. Peter Mason ADHD and Psychiatric Services Limited, which is Care Quality Commission registered and based in Liverpool. Dr. Mason has won innovation awards to pilot ADHD services in prisons and community drug services, and has published papers on outcomes in ADHD and ADHD in psychosis. He is also a collaborating author on other publications, including ADHD and the criminal justice system, ADHD in women and ADHD in the UK, a failure of service provision. For many years, Dr. Mason has worked closely with the voluntary sector and is a trustee of the ADHD Foundation. Dr. Mason is involved in various training opportunities for healthcare professionals with an interest in ADHD and speaks at national and international conferences about ADHD. Over to you, sir.
Right. Oh, thank you very much for the introduction. And also thank you for inviting me to present. It's one of the most prestigious things I've been asked to do, so thank you. What I'm going to talk about is ADHD and comorbid conditions and how we disentangle the two. And listening to the previous speaker, I think it's very interesting how we still have this dilemma about whether ADHD exists in adults or not. And the way I look at it is essentially we look at ADHD as a cluster of symptoms. To some degree, we all have symptoms of ADHD, and I think it becomes important when those symptoms start to interfere with our lives that it's maybe worth doing something about. I'll just share my disclosures and then start off with this particular slide. So when I sit in my adult ADHD clinic, so everybody I see has ADHD, but they all have comorbid conditions, or I should say at least 2/3 of them have comorbid conditions. And when we look at a particularly good Spanish study, they looked at people being diagnosed with ADHD for the first time and worked out whether they had any comorbid conditions, and at least 2/3 had at least one comorbidity. The World Health Organization did a much larger survey of adults with ADHD and found over a half had at least one comorbid condition. And if you can see the other figures there, just under 15% had 3 or more psychiatric conditions. So with ADHD, without a doubt, comorbidity is the rule, not the exception. If we look at it now from a general adult psychiatrist point of view, I'm going to present a couple of studies here. The first one is a large European study that looked at non-psychotic adult psychiatric outpatients. They screened them all for ADHD and found 47% screened positive for ADHD, which is really high. There's all sorts of reasons for that, which we'll go into later. When they looked at those 47% and did a full evaluation using the DIVA is a semi-structured interview, they found that 17.4% actually had DSM-5 ADHD. In a similar study in England, a much smaller one, they found 22% of general psychiatric outpatients had comorbid ADHD. So in other words, when you are sitting in your general psychiatric clinic, you would expect 1/5 of your patients coming through the door to have comorbid ADHD. This is the European study that I mentioned in quite a lot more detail. This is looking at the different psychiatric conditions that we see in general psychiatry. And probably one of the most common conditions we see is depression. And you can see nearly 1/8 of patients with depression have comorbid ADHD. And there's quite a lot of interesting work underway at the moment looking at treatment-resistant depression, where you find that the prevalence of comorbid ADHD is much, much higher. The headline figures here are substance misuse and alcohol abuse, where nearly 1/3 of patients with those conditions have comorbid ADHD. The bipolar figure is really quite striking. So 1 in 10 people with bipolar disorder have comorbid ADHD. There's an American study, which is actually much bigger than the European one, puts that figure at nearly 20%. So a really high proportion of patients with bipolar disorder have comorbid ADHD. And it's interesting that the reverse is also true, that amongst people with ADHD, you expect to see at least 10% with comorbid bipolar disorder. Previous speakers sort of paid attention to DSM and ICD classifications of ADHD, and I just want to draw your attention to the symptoms that we collect in order to make a diagnosis of ADHD in adults. And essentially, you need 5 or more symptoms of inattention, or you need 5 or more symptoms of hyperactivity, impulsivity, or 5 of both. So you can have diagnosis of inattentive ADHD, you can have combined ADHD, or you can have ADHD which is just hyperactive stroke impulsive. So a whole range of things. But when you look through those symptoms and think about everything we see in our general psychiatric clinics, we can see that an awful lot of our general psychiatric patients have these symptoms, whether or not they've got ADHD. And so let's just go through those in some detail. If we look at ADHD and major depression, what you can see is that there's an awful lot of shared symptoms. So low motivation, problems with concentration, restlessness or agitation, difficulty with sleeping, irritability, memory problems, etc., are symptoms that are common to both depression and ADHD. There are some differences with ADHD, the excessive talkativeness, racing thoughts, impulsivity, you generally don't associate with depression. And I think the biggest key is that with ADHD, the symptoms are there all the time. It's a chronic course. Whereas with depression, it can come and go, it's episodic. And I don't really think many psychiatrists would have difficulty disentangling ADHD from depression. But of course, the important thing is that often the conditions occur together. And that's where we've got to be really alert to the possibility of ADHD in our depressive patients. What is the link between ADHD and depression? An absolutely massive project, a meta-analysis, genome-wide association studies showed that major depressive disorder has the highest positive genetic correlation with ADHD. There's more to it than the genetics. What about life events and negative experiences? If you've got ADHD, this is likely to influence how you process difficult events. And we also know that negative life experiences are more common in ADHD. Emotional dysregulation is recognized now to be a very important symptom in ADHD, although it's not in the research criteria. But that in itself is a risk factor for developing depression. Also, the excessive spontaneous mind wandering that happens in ADHD, this is in relation to dysfunction in the default mode network. The default mode network is the network that's busy when our minds are wandering. In ADHD, it's very difficult to switch that off, so your mind continues to wander when you should be paying attention to something. And that dysregulation is also thought to increase the risk for developing depression. If we look now at ADHD and bipolar disorder, I think ADHD and hypomanic episodes are almost indistinguishable. The shared symptoms of impulsivity, hyperactivity, inattention, and mood swings are common to both. Clearly, the degree of the symptoms is that much more extreme in your hypomanic or manic episode. When you look at the course of the condition, again, this is what gives us the clue as to what's ADHD and what's bipolar disorder, with bipolar disorder being a very clear episodic course, with ADHD following a more chronic course. If you look at ADHD and bipolar disorder when they occur together, so there's a couple of studies here that compared adults with ADHD with bipolar disorder with adults without ADHD with bipolar disorder. And those who are comorbid for bipolar and ADHD have a younger onset of the bipolar disorder in earlier onset of the first affective episode, younger onset of first depressive episodes. They tend to have more frequent affective episodes. There's more comorbidity and more interpersonal violence, where bipolar disorder is comorbid with ADHD. So I think that whenever we see a patient who's presenting with bipolar disorder at a very young age, it's highly likely that they will have comorbid ADHD, and we should look for that. In terms of what are the potential underlying mechanisms, family genetic studies find that ADHD is significantly more prevalent in relatives of individuals with bipolar disorder and vice versa. So in other words, if you have a patient with bipolar disorder, the rates of ADHD in their relatives is much higher than the general population, and vice versa. When I look at my ADHD patients and ask them about family histories of bipolar disorder, it's much higher than one would expect in the general population. Genetic effects seem to account for 64% of the correlation between the two disorders, with variations in calcium channel signaling genes being more associated with ADHD and other disorders, including bipolar. Whether there are shared factors between ADHD and bipolar disorder which can explain this, so far the results have been very inconsistent. What about ADHD and anxiety disorders? Again, a number of shared symptoms: mood swings, restlessness, decreased attention, difficulty concentrating. But one of the main things here is that the inattentive symptoms tend to only occur when an individual is in a period of anxiety, whereas within ADHD, the symptoms again are chronic. It's very interesting when you look at anxiety disorders and ADHD, when you look at the lifetime risk of anxiety in people with ADHD versus those without ADHD, you can see that the lifetime risk of ADHD is significantly higher if you've had ADHD in childhood. The age of onset is much younger if you have ADHD in childhood, and the severity of the anxiety symptoms is higher if you have ADHD comorbidly. The European study that we talked about earlier looked at anxiety disorders in quite a bit of detail. And one of the things that was fascinating was if you have ADHD treated in childhood, you find that the rates of anxiety are significantly lower at 28% than those whose ADHD wasn't treated at 45%. So it does seem that if you can get in early, treat ADHD in childhood, you can really have a positive impact on the development of anxiety. Okay, this is much more tricky, borderline personality disorder and ADHD. Because they both have a chronic course, it's harder to disentangle the two conditions. And the sort of headline symptoms of both conditions, the affective instability and the impulsive behavior, is common to both. But clearly there are differences. The emptiness, the fear of abandonment is so much more associated with borderline personality disorder, as indeed the self-injury. With ADHD, you've got your hyperactivity, your attention deficit that doesn't tend to happen with borderline personality disorder. In terms of what are the potential underlying mechanisms between the two conditions, well, children with ADHD are at an elevated risk for emotional abuse and neglect, with sexual abuse, physical neglect much more common in females with ADHD. An exposure to such traumas may increase the possibility that a child with ADHD will develop borderline personality disorder. There's also a really high correlation between the symptoms of ADHD and borderline personality disorder with respect to the genetics, which demonstrate 49% of the correlation could be explained by additive genetic factors and 51% by unique environmental factors. If we look at the neurobiology, the default mode network, that part of the brain that's active when we're daydreaming, patients with borderline personality disorder have grey matter abnormalities in the default mode network and the frontal limbic circuit compared with controls. And we know in ADHD there's reduced network homogeneity within the default mode network. And so it does appear that there's some commonality there between the ADHD and borderline. Emotional instability is an interesting one, that clinical dysfunctions of top-down regulatory networks can be associated with non-emotional control, like in ADHD, or emotional control, like in borderline personality disorders. And as the networks can be associated with both emotional and non-emotional control, there's this real potential for overlap between the comorbid states having poor capacity for emotional processing. So what do we do when we have comorbid conditions? How do we treat the ADHD? Do we treat the ADHD? And my view is that we shouldn't be depriving patients of treatment of their ADHD. Not only will it help resolve functional impairments associated with the ADHD, but there's a really high chance that we can make the treatment of their comorbid conditions that bit better if we treat the ADHD. But which condition do we treat first? Essentially, go for the most severe disorder first. And this is particularly important when we have somebody who has comorbid psychosis or comorbid bipolar disorder. If those conditions aren't treated first and we introduce stimulants, we will definitely precipitate relapse. So that's really important. Never treat ADHD in the absence of treated psychosis or treated bipolar disorder. So if the anxiety and depression your patient may have is relatively mild compared to the ADHD, treat the ADHD first. And one of the things that I come across time and time again is how many patients that I see have had failed treatments with SSRIs, for example. When we treat the ADHD, their anxieties and depression seem to disappear as the ADHD is treated, because I think ADHD has such an important role in those two conditions, both in the etiology and for the maintenance. You can combine treatments for ADHD and comorbid disorders. Basically, stimulant medications can be combined with almost anything. I mean, obviously read the small print, but they are safe drugs to combine with other psychotropic drugs. And obviously, when we're deciding on treatment, let's involve our patients. If it's really complex, let's seek advice from a specialist. I mentioned before how important treating ADHD in childhood is with the development of comorbid disorders in adulthood. This is a relatively small study from Norway, where they looked at a number of children with ADHD that were treated in childhood with a number of children who had ADHD that wasn't treated in childhood. And you can see from this graph that the treatment in childhood results in a much lower prevalence of depression or anxiety in adulthood, reduced significantly alcohol problems, mood disorder questionnaires, positive screening is reduced. And overall, when you look at treatment for other psychiatric conditions from ADHD, treatment in childhood for ADHD results in a much, much lower prevalence. Of the other ones, the ones that don't reach statistical significance, the drug problems and the bipolar disorder, I think the bipolar disorder is, it's a very genetic condition, whereas with depression or anxiety, it could be that the presence of the ADHD leads to the development of depression or anxiety. Let me move on, because I think the drug problem ones is a particularly hot topic, with a number of studies, mainly in the States, that looked at treatment of ADHD in childhood, and they compare medicated versus non-medicated subjects with ADHD, and you can see that pharmacotherapy is associated with an 85% reduction in risk for substance misuse. Another study found that substance misuse was much reduced among boys for those who had their ADHD treated as children compared to those who hadn't. And prior treatment with stimulants was associated with subsequent decreased risk for substance use and cigarette smoking in girls. However, this is controversial, and a meta-analysis looked at 15 really good longitudinal studies, and they basically find that treatment of ADHD with stimulant medication neither protects nor increases the risk of later substance misuse. One of the worries has always been, if you treat people with stimulants in childhood, does this increase your risk? Does it lead on to different drug use? And the answer to that is no. And another small study, this is looking at treating adults with ADHD with comorbid substance misuse. This is a population of prisoners, and part of the requirement for release included treatment of their substance use. And of the 60 prisoners they looked at, 30 had treatment for their comorbid ADHD, 30 did not. And of the treated patients, most of those were they were much more likely to have no known substance misuse at follow-up, less likely to need rehabilitation, and more likely to be employed at follow-up. There was no significant difference between mortality between the two groups. This is a fantastic review article by Chang and others, published in 2019, which looks at some of the pharmacoepidemiological studies into ADHD. And essentially what this table shows you, this forest plot, shows you that those studies falling to the left of the dotted line have significantly improved outcomes compared to those on the right side who have worse outcomes. And what you can see here is across the board, injuries and traumas are reduced significantly when ADHD is treated in adulthood. The traffic accidents again are reduced, apart from one study in females, but that didn't reach statistical significance. Criminality is reduced, suicidality is reduced, substance use is reduced, depression is reduced. So all of these conditions, if you treat the comorbid ADHD, you find really positive outcomes in the comorbid conditions. The bipolar study, this is a study by Victorin et al., showed what we all would expect. If you treat somebody with a bipolar disorder who isn't on mood stabilizers with a stimulant drug, they relapse. If the person is on a mood stabilizer, then what we find is that not only is the ADHD treated, but the outcome of the mood disorder is better as well. Let's just show you that in a bit more detail. So this is the Victorin et al. Study. Basically, they looked at treatment emergent mania with methylphenidate, and they found that the rate of manic episodes within 3 months of starting in patients with bipolar disorder not taking mood stabilizers had a hazard ratio of 6.7. So a really, really high rate of manic episodes there, high rate of relapse. But for patients on mood stabilizers, the risk was in the other direction with a hazard ratio of just 0.6. And I think this is a really important message. If you've got patients with bipolar disorder who have a young age of onset, frequent episodes, you need to think about ADHD. Not only do you need to think about ADHD, but once you've treated the ADHD, once the person is on a mood stabilizer, then do think about treating the comorbid ADHD, as this will have a positive impact on the outcome for the bipolar disorder. Towards the bottom of that, this same table, psychosis. So if you have psychosis and you decide to treat the ADHD with stimulants, it doesn't seem to have much impact on outcome of the psychosis, neither positive nor negative. This is again quite controversial, because there's always been this worry that if you're treating people with ADHD with stimulant drugs, we all know the dopamine hypothesis in schizophrenia, it would make sense that if we're treating people with stimulants, we may precipitate psychosis. And there was, the study quoted there is that there's no overall increase in incidence. But in the New England Journal of Medicine in the same year, in 2019, 3 years later, they looked at adolescents and young adults with ADHD, receiving prescription stimulants and looking for their new onset of psychosis. This occurred in 1 in 660 patients, which was thought to be higher than expected, and they found a particularly higher incidence with amphetamine use rather than methylphenidate. Shortly after that article was published, Cortese published a response, and this is really very important, that the study didn't control for persons who were of low vulnerability for developing psychosis. In other words, the psychosis would rarely develop even if exposed to stimulants, versus those with high vulnerability, where the psychosis is likely to be precipitated by stimulants or even no exposure to stimulants. So I think, again, the message is if you have got somebody with psychosis, treat the psychosis first and then think about starting the treatment for the ADHD. One of the worrying things, and this has happened to me, I had a young woman who had schizoaffective disorder. She was on a combination of olanzapine and also Depakote, which is a dreadful choice for a young woman. But her psychosis was relatively, well, it was controlled. We started treatment with methylphenidate, and she got really better, much better. Her functioning improved. In fact, she was so much better, she thought she didn't need her antipsychotics anymore. She stopped her antipsychotics, immediately relapsed, and sadly took her own life. So we've got to be absolutely sure that if we're treating people with psychosis or bipolar disorder, not only do they need to be on their mood stabilizers or their antipsychotics, but they need to stay on them. So in summary, ADHD is a highly comorbid condition. It's a frequent comorbidity in patients attending general psychiatric outpatients. So about 1 in 5 of your patients in general psychiatry are likely to have comorbid ADHD. The symptoms of ADHD are very similar to those in other psychiatric conditions. They often share similar etiologies and neurobiology, and ADHD can be safely managed where there are psychiatric comorbidities. And at that point, I will finish. I will stop sharing my slides, and I think
Thank you, Dr. Mason, for that interesting session. We do have 10 minutes for the question and answer session, and I'd like to invite Dr. Ratnayaka to the head table for the Q&A session, and Dr. Mason would be joining us virtually. Now the floor is open for the discussion.
Hello.
Yes. Yes.
Right. Thank you so much, Dr. Ratnaik and Dr. Mason, for this very informative lecture, and there are lots of new information as well. We learned quite a lot actually. Thank you so much for that. And so ADHD, so in my clinical practice also, I have seen so many people which are suggestive of diagnosis of ADHD. But the more closer you look, you feel that this guy is a bit irresponsible and not well disciplined and procrastinating things like that. Sometimes some of these symptoms could be attributed to their personality, the way they brought up and things like that. So adding that to actually one of my colleagues, so he was supposed to do kind of a quite a important work, and he has not been doing for a long period of time, and all of a sudden he has done it in 1 week. Then I asked how you did that. He said that he has taken methylphenidate for that 1 week, and he sat in front of the table and finished it in one go, right? So that I feel that sometimes in normal people also, and improved with methylphenidate. Right. Having said that, I really appreciate this concept of adult ADHD. I think that diagnoses do exist, and so we need to learn more, and we need to kind of develop facilities even in Sri Lankan setting to pick up more patients and do appropriate treatment. So I would like you to answer my question, if you don't mind, Dr. Ratnaik and Dr. Mason both. Thank you.
Peter has more expertise and experience than me. So over to you, Peter. What's your view?
Yeah, I mean, that's a really, it's a really interesting question, that. And I think really the question is about, can we use stimulant drugs as performance enhancing drugs, even if we don't have ADHD? And there's always been a lot of controversy about this, because students will buy Ritalin online, they'll buy modafinil online, and they believe that can really enhance their performance when they're revising and when they're sitting their exams. There's quite an eminent researcher in the UK who's studied this in some detail and has actually found that stimulants are not very good at enhancing academic performance if you don't have ADHD. And it's difficult to know why that might be. Possibly it's a result of state-dependent learning. So if, for instance, you are taking a drug whilst you're revising, you can only retrieve those memories if you're in a similar state in the exam. So if you take a drug while you're revising and not in the exam, it becomes really hard to retrieve those memories. And I think the other thing is that of those patients who do well when they take their stimulant drugs, if they don't have a diagnosis of ADHD, then my inclination would be help to look a little bit harder to see whether in fact they do have ADHD. Because the normal response when people take stimulant drugs who don't have ADHD is to feel really sort of edgy and jittery and not yourself. With the slow release forms of methylphenidate or amphetamines, you can't really get a high from those. So it's one way of disentangling those who are going to really benefit from the drugs for studying, say, and those who aren't. And I suspect a lot of the people, when they take them for studying, they get a heck of a placebo response because the drug does make them feel different. So I'm not sure whether that answers the question.
I do really appreciate the great presentations by both speakers. I would like to do a comment and as a question as well. Going back to the emphasis on the critical appraisal by Dr. Pessing yesterday, I was thinking whether, sometimes evidence-based can be evidence-biased. Considering some of the conditions which are promoted, especially when there's a medication involved, I might be very critical here, but as scientists who are very good at critical appraisal, I think that's one way we need to think as really responsible profession in going future. Even when DSM-5 came, there was a lot of criticism against for DSM-5 for medicalizing normal behaviors. And also the other trouble with ADHD, adult ADHD especially, as Dr. Varun Idisilla said, like we don't have a PCR test for COVID. So that is a difficulty, as Dr. Ratnaik also really, appraised the difficulty here. That's why even recently I attended a conference where there was a debate about ADHD, adult ADHD. So it is a contentious thing, and Dr. Mason clearly mentioned about the comorbidities. Now, from my context, based in South Australia, I work in a small private practice where I see patients only on Wednesday. When I go there, there's a pile of referrals for ADHD. These people come with the preconceived idea that they have ADHD. And they were also told by various people they have ADHD. But from my thorough training in Sri Lanka with these very great teachers that I have who are here in the room as well, looking at the psychopathology, whether this is hypomanic episode or whether this is normal, normal elevation of mood or normal mood fluctuation. And then considering fully assessing the person over a few sessions, looking at the formulation, I mean, I had to exclude ADHD on most of the patients. But I still do treat patients, some patients successfully with lisdexamfetamine and so forth. So my question is especially for the experts and the speakers, what your experience as to how many, what kind of percentage you would exclude in your referrals not to have ADHD? Thank you.
It's a very good question, and it's the dilemma you get as a clinician when you are aware about the ADHD, adult ADHD. And I had a similar problem when we started the ADHD surveys. Many people, as I said, when you get the self-rating, and many people highly rated themselves as having an adult ADHD. And also, there have a lot of advantages having a diagnosis of adult ADHD. That's why you need to be very vigilant. It's a double-edged sword in some sense. Because if you have adult diagnosis of adult ADHD, in UK, Royal College of Psychiatrists has now decided for their exams, they are getting extra half an hour. Also, many benefits they are having. They are getting the benefit if you have a mental health diagnosis, and insurance purposes, all these things matters for them. So that's why it should be very vigilant. But in my view, you shouldn't completely ignore that. And also same time, don't just include everything. So it is need to be very vigilant in that source. That's why I said you shouldn't underdiagnose it. You shouldn't overdiagnose it or undiagnose it. Thank you. By Peter.
It's again a really important question, and in answer to the question about how many people do I not diagnose ADHD, it's about 5%. But you have to bear in mind that the people that I see are people who've waited a long time for the diagnosis. The waiting list on the NHS can be in excess of 8 years to get a diagnosis. So when they come to see me, they've often put a lot of thought into it. They've often researched the condition. And I find that most of the people who've done decent research into the condition are usually right when they think they've got ADHD. The other thing that some of the patients that I get to see have had, now there isn't a diagnostic test for ADHD. There isn't really a diagnostic test for most of the things we see in psychiatry. But we're getting close in ADHD, and there's something called a QB test, which is a piece of computer software which can measure people's ability to concentrate. And it's done basically by a very boring piece of computer software which flashes up different shapes of different colours. And the patient is supposed to press a button when two shapes of the same colour match, and not to press the button when they don't match. And so from that you can get an objective score for their ability to concentrate. You can get an objective score for their impulsivity when they're pressing the button when they shouldn't. And they also have an ability to monitor and track the person's movements. So you can also get a score for hyperactivity. And what's good about the QB test, I mean, it's not brilliant as a diagnostic tool. It helps and it gives you some objective measures. But what's really good about it is when you treat the person and you repeat the QB test, you can see the change in the symptoms. Now, the drawback of the QB test is that it's not very good when there are comorbid conditions present. But they have used the QB test for conditions like bipolar disorder, depression, anxiety, and it's not really any use in diagnosing those conditions, if you like. So the poor concentration associated with anxiety shows a very different pattern to the concentration problems with ADHD. So the search for a biological marker goes on for ADHD, and you know, hopefully we'll get there one day.
Yes, we have come to the end of this session. Dr. Dahanayaka will award the certificate to Dr. Tilak Ratnayaka. Thank you, Dr. Peter Manson. Thank you very much for your wonderful presentation.
Yeah, thank you for inviting me. It's been a real pleasure to be with you.
Thank you, madam. Next up, we will be having the presentation on mental health service development by Dr. Anuradha Allepula, who won the award for the Best Regional Psychiatrist of the Year for the year 2022. We are sure it will be an inspiring presentation to all of us. Over to you, sir.
Thank you. Good afternoon, dear ladies and gentlemen. So I'm going to present a few slides about the mental health development we have done in Rajarata in Anuradhapura district over the past few years. So if you take Anuradhapura, Rajarata, it's a very interesting place. Right? So I came to work in Anuradhapura in 2014, and the main community is farmers. And if you take the last couple of years, politicians try to give their advices how to do farming to the farmers, professional farmers. Right? They told them how to cultivate. And ironically, the politicians had to take advice from some of the celebrities in Anuradhapura district, how to rule the country. Right? And so those things actually really affected the communities in Anuradhapura. And in addition to that, the human-elephant conflict is still existing, and no one has found solutions for their problem. So development of services in Anuradhapura was quite challenging. So despite that, together with the staff and the patients, we managed to develop a significantly develop the services in the Anuradhapura district. So we had some concepts and principles in mental health and in medicine to develop services in Anuradhapura. Otherwise, the service development is not sustainable. We can't just randomly do service development. So clinical governance is something that we really take into consideration in service development. And also when we are developing services, we have to audit the existing system and see the gaps in the services. And then we need to have a good project proposal, a design, and then we have to implement the service. And after that, we have to find whether the developed service is functioning well and have to see the gaps in the developed service. And some of the quality improvement tools, so you know all this. And something we really believe in is the organizational culture that actually keep the bonding between the staff members, and actually to get the help of the staff, the rapport of the staff, have a clear organizational culture is important. So when you're in Rome, you have to act as a Roman. So when I went to Anuradhapura in 2015, one of the things I realized is that there's a very, very strong religious background in Anuradhapura. So this is the first thing the staff and the staff and the patients requested from us. They need to have a place for their religious observances. So in 2015, we established a religious place for the observances of the patients and the staff. And we had a problem in the outpatient clinic because the patients had to wait in the corridors until they had their turn. So we had to build a waiting area for the patients to rest. So developing services in the places, especially in the peripheries, one of the problems is the financial provisions, right? So this thing we got it done through the government, and the estimate was 4.8 million for this small shelter, right? So we don't know how the budgets were allocated for these small constructions, right? So this a major project we did in 2016. So we converted the abandoned theatre complex into a fully functional day center. We did not have a day center during that time. So it's still functioning really well. And this is the opening ceremony where the Sri Lankan College of Psychiatrists and came and inaugurated. We have a 50-bedded inpatient, acute inpatient unit, 25 male beds and 25 acute female beds. So these are some of the activities that's happening in the inpatient, acute inpatient units. And another major service we had to develop was the occupational therapy unit. We did not have one before that. So we had to, with the donations of some of the companies as well as well-wishers, we established the occupational therapy unit. It's very well functioning, and it serves the patients, especially when they need some rehabilitation. And even assessment of the functional assessment of the patients is done in the occupational therapy unit. And we initiated a new clinic in the elders' home, which is in Saliyapura. And this is one of the functions where we organized and distributed some reading glasses for the elders with the help of a foreigner from Switzerland. So in 2019, the COVID-19 affected the services, and the wards were contaminated, and so many patients got positive with COVID. And we had to give some donations to screen the patients before they were brought into the inpatient units. Otherwise, we had to transfer patients from inpatient units to the COVID units, and they really did not like, the COVID units did not like to have psychiatrically ill patients in their wards, especially because they believe the patients are quite aggressive. So we had this screening place where, again, donations helped us to get these huts, tents, to screen patients before they moved into the inpatient units. So these are the COVID units. We established 2 COVID units for the patients with acute psychiatric illnesses in our male and female wards. Again, we had to get donations for this acute inpatient COVID units. So that helped us to manage the patients within the mental health facility without transferring them to the acute COVID units. So we had to monitor the patients when they are in the COVID units, because the staff movement should be minimized when we are managing patients with COVID positive results. So we had to establish a CCTV system to monitor the patients in the units. And this is a duress alarm system. We again installed in 2021, because we had a major incident in the wards where a group of patients from armed forces conspired against the staff, and 2 of the staff members were critically injured after they assaulted on the staff members. So we did not have a duress alarm system at that time. So again, we found some donations and installed a duress alarm system. And we want to attract people from the vicinity in an acute incident. So Sri Lanka College of Psychiatry always helped us in the service development. So this is one of the regional meetings we had in Anuradhapura, and we discussed about further service developments, our plans for the future, and also we had serious discussions with the regional director and the divisional directors, and had some service developments in place with the help of Sri Lanka College of Psychiatrists. So in 2022, this year, we conducted the first regional psychiatry sessions in Anuradhapura. So it was well attended, and we had a participation of more than 100 in the regional psychiatry sessions, despite there were so many problems because of COVID and other issues in the country. We could attract a good crowd. It was a hybrid event. And we are planning to have these regional psychiatry sessions in Anuradhapura annually. Right. So this is the mother and baby unit we started again this year. Right. We did not have a mother and baby unit, and we had to keep the babies in the neonatology unit or the pediatric unit and treat the mothers in the acute inpatient unit. It was not very successful. And if you have difficulties, you have to transfer the patients to NIMH, where they have the mother and baby unit. So we had 2 mother and baby beds, again with the help of donations. So what we did was we converted the female COVID acute inpatient unit to the mother and baby units. So we have treated some patients so far, and it's again a successful project. So we can treat 2 patients at a given time. And again, these are some of the donations. We have a very dynamic senior registrar now, Dr. Madhura, and she coordinated a backup ECT machine to the unit. So in a case the ECT machine is not functioning, we have a backup. And to improve the ventilation, we got some donations from companies and well-wishers to improve the ventilation facilities. So these are some of the teaching sessions we have. So we teach medical students, registrars, and senior registrars. And this is the pre-COVID and post-COVID. Their dress codes changed, right? So they are really getting benefited because the exposure is really good. We have a very good mix of cases in the wards as well as in the clinics. So they're getting really benefited during their appointments. This year again, we created a logo for the unit. And with the help of a professional logo designer, we got this done free of charge, right? And we are using this for correspondence, including in the letterheads. Right? So these are some of the research we did in Anuradhapura since 2016. And we have done some audits as well in order to improve the services and to find the service gaps. Right. And I'd like to acknowledge the Sri Lanka College of Psychiatrists to giving me this award, and all my teachers, mentors, and senior consultants, colleagues, Mental Health Directorate, administrators of health in North Central Province. And they're quite helpful, the administrators, especially the provincial director and the regional director. They're always helping us with the service development, and also the family for right, tolerating me as a weekend husband, right? And also Dr. Chamara Vijay Singh, who encouraged me to apply, my friend, my colleague, my batchmate, MD batchmate, encouraging me to apply for this award. And staff of the mental health unit. It's really good to see how supportive the staff is. And without their support, we cannot develop any services. And also the donors. So in development of services in peripheries, really difficult without donations. So we attract a lot of donations from companies and well-wishers, right? And also the service recipients. So to show you some pictures of Anuradhapura, if you have not seen, right? It's a very attractive place, very tranquilized place, and there are some nice hotels in Anuradhapura. And I would like to invite the trainees as well as doctors, right, to come and work with us in Anuradhapura. It's a very nice place, and you have a lot of, so this some of the sceneries you'll find around Anuradhapura. And we have all the Atamastan and all that. You can have a very relaxed time. Right, thank you. Thanks.
Thank you, sir, for that wonderful presentation. Ladies and gentlemen, next up we have the most weighted events in our sessions. A battle of wits between 2 groups of eloquent consultants, and this year's topic will be on whether grade 5 scholarship exam should be abolished in Sri Lanka or not. Abolished in Sri Lanka. And it's my pleasure to invite the judges of the debate, Dr. Danny Sullivan and Professor Shehan Williams. I cordially invite our moderator today, Dr. Chamara Vijay Singh, to the stage.
Right. Good afternoon. Welcome to what I believe will be the most interesting session at these academic sessions. And we are going to have a debate on the grade 5 scholarship exam, whether it should be abolished in Sri Lanka. many of us here have done the exam. Our debaters here, some of them have done this exam at the age of 10, and all will have reasonably good, or in my case, even though I didn't do it, a very traumatic experience. I remember my year 5 final term exam very well, because that was the last time I was ever first in anything. The next term in year 6, I was 17th, and I looked and saw 16 brilliant students, and I was so demoralized, and it took me years to get over that. And so who were these kids? 10 years, unbelievable. And now looking back, one of them went on to be Island first at maths, and he is lecturing at MTI. Another one of them is a consultant, VOG, very popular. Also, there is one, when I look back, who passed away around the age of 30. Nobody knows, possibly suicide. And recently on our school group, there was another sort of group message circulating to collect money for another one of these kids who had come into school who's not doing so well in life. So it is a strange phenomenon. And to propose that the grade 5 scholarship exam should be abolished in Sri Lanka, we have a team comprising of Dr. Ferdinand Pereira, of the consultant psychiatrist at the Sri Lanka Army, Dr. Suhashini Ratnatunga, senior lecturer and consultant psychiatrist at University of Colombo, Dr. Achini Samaranayaka, a senior registrar at National Institute of Mental Health, Angoda. And opposing this view will be Dr. Madhuri Senanayaka, consultant psychiatrist and senior lecturer at University of Colombo, Dr. Muru Chandradasa, consultant psychiatrist and senior lecturer at the University of Kalaniya, and Dr. Dinusha Sirisena, consultant psychiatrist at DGH, Mana. How it works is each speaker will have 7 minutes to talk, and that will come to 42 minutes. At the end, 5 minutes each for the team leader, and the 2 judges, Professor Shahan Williams and Danny Sullivan, will wrap things up in 8 minutes at the end. So we start off with the proposing team, Dr. Ferdinand Pereira.
Thank you very much. The President of the College and respected ladies and gentlemen, today we are proposing grade 5 scholarship exam needs to be abolished. Now, getting into this topic, I might clarify that further. We have to take actions to stop crucifying our loving, innocent 10-year-olds, at least now. I will illustrate the records at the first speech. These, my dear opposition colleagues, we are not here talking about adding any amendments to existing scholarships exams. No. And we are not talking about Japan or Singapore. It's Sri Lanka. Next one, we are not going to talk about changing, improving, or any repairing processes for this existing scholarships exam. It's very clear. I believe that you all are bright academics. Stick to the topic. Grade 5 scholarships exam has to be abolished in Sri Lanka, the topic. So, ladies and gentlemen, now let me tell you, the composition of the scholarships exam is paper number 1 and paper number 2. Paper number 1, yes, fairly okay. It assesses the general intelligence. Number 2 is the disaster. You can have the potential of having any question under the sun in that paper. We will elaborate it further, don't mind. For the record, a senior research fellow, Dr. Sujata Gamage, had done an excellent study on 2019. She had gone through year 2000 to 2016 past papers of scholarships exam. She has noted questions pertaining to 100 plant types. Are we producing botanists for grade 6? I don't think so. And believe me, my personal experience, once I have spoken to a principal in a leading primary school in Variyapula to plead to stop a teacher conducting scholarship classes from 4 a.m. to 10 a.m., then the same day 4 p.m. to 10 p.m. because he believes that's the best time to pump knowledge into 10-year-old's brain. Principal reluctantly agreed, but she told me, oh my God, doctor, he is the best teacher we are having. So this is a condition we are dealing with. And then we have the statistics. Next important part. The total number of students sitting for the scholarships exams per year, 350,000. Only 20 to 30,000, maybe let's say 25,000, go through the cutoff mark. So that is staggering 8%. 8%. That is inhuman. Why it is inhuman? 92% of that age group children we are labeling as failures. It is unfair. It is monstrous, isn't it? So the label we are going to give them at that early age is, I'm a failure. I'm inadequate. I have betrayed my parents, my teachers, my school. Gosh, that is infuriating. That is ridiculous, isn't it? So I can't imagine the personalities of our three opposite members, that how come they are recommending this thing to be continued for another few decades at least. So please think wisely. Now, again, I need to highlight, we are talking about 92%. Some of you will feel, okay, we have done this, so that's no big deal. We all came across, that is how it should be. But please, we all are sitting here because we had that privilege, we went through that. But there are many other people. Remember about your friends, and as psychiatrists, all of us, we are seeing dissociative fits, somatoform syndromes, students refusing to go to school, social phobia, OCDs, even when they are 20 years, some of them you can trace back to the onset to the grade 5 scholarships exam. Oh, that is unfortunate. So here we are talking about this monstrous exam, and now let me take you to these objectives of the exam. That is the most hilarious part. Objective number 1, identifying clever but disadvantaged students. Objective number 2, providing them with bursaries. So now we have to see, after these decades, whether these objectives are fulfilled. For that, I have this very good comprehensive study done by Institute of Policy Studies. It was done in 2019. They have very comprehensive, very thorough study. I have the study with me. I can pass you if you need that, Lidusha. But yeah, so after doing this thorough study, they have said, grade 5 scholarships exam, as they perceive, it's a failure. Because, number 1, low admissions to grade 5, grade 6 based on a scholarship's performance. I'm sure that all of our opposition members realize that their mother schools, how many classes they are accommodating for grade 5, grade 6 entrances through the scholarships. Number 2, poor performance of the schools which should be benefited highly from grade 5 scholarships exams, because already they are disadvantaged. Now they have to compete with other schools. Number 3, poor quality and unequal distribution of teachers. Shortcomings in the exam in identifying the intelligent student. We are promoting a culture of rote memory. The next one, question predictive validity of the exam. In 2015, there was a study conducted by Eastern University Sociology Department. They have found out the scholarships exam has no significant bearing on receiving professional qualifications subsequently. So please, ladies and gentlemen, think these topics, think these points, and think about our young, innocent 10-year-olds. Do we need to crucify them? I don't think so. So let's see about the other party's opinion, what they are going to say. Thank you very much.
now we'll have Dr. Madhuri Senanayake from the opposing team.
Respected judges, Chairperson Sir, members of the proposition, members of the opposition, and members of the House. We are here today to debate the topic, the Year 5 scholarship exam should be abolished. And as the leader of the opposing team, I am here to tell you why we firmly believe this should not happen. If I am to take you through a little bit of background, the Year 5 scholarship was begun in this country in 1948. And this was shortly following the Free Education Act, which was passed by Parliament in the mid-1940s. And for the past 74 years, this exam has been continually maintained, run, and successfully completed by millions of students in this country. Essentially, what it does, as I agree with the leader of the proposition, is to place children between the ages of 9.5 and 10.5 before a competitive examination involving currently involving the areas of non-verbal reasoning, verbal reasoning, language, arithmetic, and a small number of questions relating to rote memory of subjects relevant to the environment. Now, while the purpose of this exam, Year 5 scholarship, is twofold. Primarily, the objective is to provide students with better schools. And this is especially relevant to students from more disadvantaged backgrounds, whether those are more disadvantaged families by financial means and socioeconomic deprivation, or students who are in particularly rural settings whose schools lack the basic resources to provide robust education. In other words, these are students who are being held back by their circumstances. And these students, should they achieve a high mark at this examination, will move on to better schools within the district or beyond. The other part of the examination, which admittedly is less significant, is that a certain number of students whose families would qualify based on socio-economic grounds for a bursary will receive an amount of money of approximately, currently I think it is a mere 750 rupees monthly till the end of their school education. So, my colleagues and I agree this is an exam which has significant problems. The second speaker in my team is himself a child and adolescent psychiatrist, and we too share concerns about the potential emotional impact of a competitive exam at this age. There is the fact that the students have to change schools. There is the fact that the students may move further away from their homes. And ultimately, there is the question of whether all of this is or is not worth it. For the parents, the decision or the planning for this examination begins long before the child reaches the age of 7, 8, or even 9 years. Oftentimes, they are placing a huge burden on themselves to prepare their children for this examination. The children themselves are taken through tuitions, and as the leader of the proposition mentioned, these can in certain instances be ridiculously long. We concede that is true, and that is a drawback of this examination. There is the fact that there is inequitable, unequal resource allocation between schools in the country. There are schools which are under-resourced, and there are schools which are well-resourced, which continue to be more and more resourced. And what this does is move students who have been high achievers at a competitive examination, assessing primarily factors relating to IQ, and it moves these students together, takes them away from certain schools, it collects them, pools them in certain areas, in certain other schools, which are admittedly often the more resourced, and this cycle continues. Society pays for all of this. This is all true. However, the policy motion under debate today is that the Year 5 scholarship should be abolished. We concede there are difficulties with this examination, and we agree, we would be the first to agree, that it certainly needs modifications. But I have personally, and together with my colleagues, failed to identify a viable, let alone superior, alternative in the reality that we live in a society which is poor in resources. That is especially true of our country in its practical economic freefall at this time, but nevertheless it is also true that, that demand outstrips resources in every society, and that is one of the fundamental tenets which drives an economy. So, in that situation, we feel that it is still the best option available to continue to conduct the Year 5 scholarship. However, we concede that there are certain modifications in this program which are required, which I will leave my second and third speakers to further elaborate to you. And I end by mentioning that we remain convinced that abolishing the Year 5 scholarship will not resolve the problem in a suitable manner without causing essentially more problems than it solves. Thank you.
Thank you, Madhuri. The next speaker from the proposing team will be Dr. Suhashini Ratnatunga.
Good afternoon, ladies and gentlemen. My dear opposition, can we address the elephant in this room? We need to focus on the main person that is involved here, and that is the child, the future of our country, and dare I say, the victim of this system. And that is what I would like to talk about. Remember, we are placing this grade 5 exam at a very crucial period in a child's life. There is a child psychiatrist there, and he will tell you that lots of neuronal networks, a child's physical, psychological development occurs during this stage. Educational psychologists will tell you that it is during this time that we need to teach our children creative skills, interpersonal skills, assertiveness training, negotiation skills, how to think critically, how to help one another, how to display kindness. But does our exam, this exam which you so confidently propose we have, does it address that? Just quote some questions that have appeared in past papers. Maluwage පෞච්ච වරල මෙන් පෙදය බෙදී ඇති කුරුල්ලා වන්නේ මින් කවරෙක්ද? I know there is a non-Sinhala speaking judge in the audience, but I'm very sorry. I haven't passed, I haven't sat the grade 5 scholarship exam, and I'm not academically gifted to translate this into English. So I'm very sorry about that. ගිරෙන් ගිරට පැන ලැබුම් සොයා යන වන්නමින් කියවෙන්නේ කුමක්ද? තම රැකියාවේ යෙදී සිටින විට ගැලටිය නැමැති නිල ඇඳුම භාවිතා කරන්නේ කවුද? හෙදිය, වෛද්‍යවරයා, මනු කියවන්නා. So are we thinking critically? Are we telling our children to broaden their horizons? Are we telling them to think analytically? So that is a question for you all. Are we measuring what we need to measure at a very crucial stage of a child's development? Oh, and sorry, one more question. I was quite surprised to see this. Write in English the following words. Iguana. Ma'am, do you know the English singular word for iguana? No. Wali kukula in English. Okay. I'm sure this forum will appreciate the influence of childhood experiences on our personal development, on our personality, and mental health issues. Remember, this exam is at 10 years old, but children and teachers start preparing our children from the age of 7 years old, from the age of 7. So the child enters school at 6, he settles down to the mainstream system, and in 1 year, the teachers tell them, you need to come back to class, you can't play for more than 2 hours. You can't be watching TV in the evenings, you need to do past papers, you need to go for this class, I'm going to enroll you in a very expensive tuition class, and you need to go for that. And then the child wonders, okay, so I'm now in school and I'm supposed to sit for this very, very, very important exam. And apparently this exam, if I do well, I will bring glory to my parents. I will put my school on the map of Sri Lanka. And if I don't pass this exam, I won't be able to go to a very popular school. And I won't be able to go into uni. Okay, so the child studies very hard, goes for the expensive tuition classes, does all the past papers, and gets 160 marks for his scholarship exam. Now this is 80% per subject. And then he is told, I'm sorry, the pass mark this year is 162. Okay. So what sort of schemas will this child develop? What sort of schemas will he have? I am not good enough. I didn't make my parents proud. I let my school down. I'm going to remain in this disadvantaged school. I'm going to remain with the morons or the idiots. Okay. So what is the scholarship exam pass rate in Sri Lanka? 8%. So do we want 92% of our population to grow up with these schemas? Or do we want students, do we want children to grow with self-confidence, self-esteem, grow up as empathetic adults? And does this exam you propose, does it address any of those issues? Okay, if we are interested in our children succeeding in school, growing up as healthy adults, then we need to provide them with an education that has context and relevance. As a society, we need to inculcate values such as kindness, empathy, the value of sharing in our children. We need to focus on the intellectually disadvantaged. We need to pick up and push students who are at the backstage. We need to pick up students who are lagging behind. We need to direct our resources towards those children, not the academically bright children who have the intellectual capacity to do well in life. We need to pick up that 92%, the majority of our population. Dr. Sullivan, I was very interested in your second talk, where you said that we need to identify the disadvantaged students early and focus on them early, before they become offenders, before they become marginalized, and before they become the unwanted. Thank you.
Thank you, Suhashini. And next we'll have Dr. Muru Chandradasa from the opposing team.
Now, I'm going to make one of the judges angry by saying, Muttiah Muratharan is better than Shane Warne. I'm sorry for saying that. He has 800 wickets compared to Shane Warne having 723. I know almost every day Muthaya Muridharan took 5 wickets, but some days he couldn't take any. Like that, the questions pointed by Suhashini are only some of the questions. Let me compare some of the questions as one of the 8 child psychiatrists in this country and as a father of a son who's going to sit for this exam in 3 months' time. And this question is from the NAPLAN test, Australian Year 7 test, National Assessment Plan test for grade 5 and 7, compared to a similar question in our grade 5 scholarship. So if you can see the NAPLAN question, it's about Kulaka or set mathematics, and the same one in Sinhala questionnaire. So here, actually, if you read it, our question is more creative and more related to sport activity at a village if you read them very carefully. So what this assesses reasoning, verbal comprehension, attention, and processing, which are very relevant for a 10-year-old who's in the pre-concrete concrete operational stage, at the end of concrete operational stage, where logical reasoning is bursting out and very relevant for that Piaget's cognitive stage. In this second question, you can see this question where there are 2 cubes and you have to guess what is on the opposite side of a certain symbol. So comparatively, in the grade 5 scholarship in Sri Lanka, we also have a very similar question. What does this assess? Visual spatial ability, processing speed, attention, and verbal reasoning. So which are very relevant for the Piaget's cognitive stage of concrete operational stage where the 10-year-olds are. Then, as one of the 8 child psychiatrists, I am so happy that my adult psychiatrist colleagues are so passionate about children and telling me that they love children so much. Thank you. So, this is one of the audits I did in my clinic at the Colombo North Teaching Hospital, where I assess all school children coming to my clinic over the last 2 years with academic related stress. These students are not pre-diagnosed ADHD, does not have autism, they are just coming to the clinic for academic related stress. Now you can see on the x-axis I have the grades, on the y-axis I have the number of students I saw for academic related stress. So you can see, yes, compared to grade 4 and 3, there's a slightly higher prevalence of presentations in grade 5, but look ahead, in grade 11, it is very high compared to grade 5, it's extremely high in grade 13. So maybe next Sunday, we can have a debate on abolishing O-levels. Maybe the subsequent Sunday, have a debate on abolishing grade advanced level. But sorry, I have other commitments. You can go ahead. Yeah. So, isn't it the responsibility of the parents to cater for the child, to be a mature parent and modify what commitment and time they spent on the exam? Yes, the grade 5 exam is there. Yes, we agree that only 10% meet the cutoff, but still, aren't you have to take the more mature role as a parent and decide, these are the hours you are going to commit your child? So you have to decide, am I going to push my worrying, anxious child and push him to go to an elite school, or decide what is best for him? So we have to look into the Yerkes-Dodson stress response curve. So when you look at it, you can understand that at any age, if the children do not have exam, they may be bored, they don't have objectives, and their performance level will go down. There should be optimum level of performance, so they'll be focused, engaged, and complete their learning tasks. Obviously, we all understand as parents, if you are irresponsible and not mature enough to do what is best for your child can become stressful. But with appropriate schedule, advice, you can keep your child in the middle component, which is appropriate for their age. So considering some of the comments made by the other speakers, Thank you, Ferdy, for telling that the paper 1 was good. We agree. Paper 2, you said they were asked 100 plant types. But if you have sat with your son, maybe daughter, and done these papers 30 times, you will understand you don't have to know these 100 plants. You can remember 5 and be smart and select the appropriate answer. Yes, you said that 92% of the students fail. That is completely incorrect. Go through the circular. The pass mark is 35 out of 100 per paper. You have to get only 70 out of 200 to pass. Yes, the cutoff is 160 to obtain bursary. But majority of the students are not focusing on the bursary. The pass rate is 35 out of 100. And going through some of the comments Suhashini made, and she said that some of the questions are irrelevant. I showed you the evidence that they are parallel with other questions in NAPLAN and PSLE in Singapore and 11 plus in UK. And we have to focus on less privileged and less intelligent students. But remember, we need more PhDs in this country. To get more PhDs, to make innovative research, we need bright students to be in a competitive environment, producing the best research in the country. We can't be China, we can't be India, because we don't have million acres to crop the same things they grow. So we have to be innovative. For that, we need more PhDs, more MPhils, so that for that, we need our brightest minds to be with other brightest minds in elite schools and doing the best for the country. Thank you very much.
Thank you, Mayuru. And now from the proposing team, Dr. Achini Samaranayake.
Honorable judges, members of the opposition and members of the House, very good evening to all of you. So the opposition has very graciously accepted some severe deficiencies in the grade 5 scholarship exam. They spoke about what a burden it is. They spoke about the burden with tuition, the immense, how taxing it is for children to move away from, to reallocate from their homes. So I'm a bit confused as to why you would still want to perpetuate a system like that. So you were saying that you do understand, and I'm very grateful that you were very frank about it, that you do understand that this has its disadvantages, but the first speaker was, I suppose she was referring to it as a necessary evil. So I guess for this kind of system to go on, a substantial number of students should benefit from it. I'm sure you would all agree. So the broad aims of the scholarship exam is to give the students better schools, to give them bursaries, and to improve skills and knowledge of the children. So according to the statistics, I'm referring to the 2017 statistics here. How much of a proportion of students sitting for the exam do you think get better schools? 50%? 30%? No, ladies and gentlemen, it's 5.9%. I'm not just pulling the statistics off my head. This is the document given by the Institute of Policy in 2017. Only 5.9% of children move to better schools from this exam, and only 10% of students even obtain a sufficient mark to qualify for bursaries. So we are talking about a 92% people who are failing to meet the cutoff mark, even though there is, I'm not sure about the different pass mark, but the cutoff mark is inexcusably high to just cater to 5.9% students who would change their schools. And among that all the students who sit for the exam, only 3 to 5% actually get a seat in a privileged provincial school. We are speaking of a very small minority, ladies and gentlemen. And the majority who actually qualify are not from poor schools. Half of the high-scoring students are from privileged schools to begin with, and the low-income students who qualify from underprivileged schools is quite low. And regarding the bursary, which the opposition was talking about as an advantage of the scholarship exam. Among those who sit for the exam, only 4% meet the cutoff mark and also qualify for the bursary. Only 4% of students are disadvantaged enough to meet the bursary requirements as well. So I'm not sure whether the opposition is familiar with the current cabinet reshufflements. Like they do so many modifications when actually what needs to happen is a much more substantial change. So I don't think you can change a system that is deeply flawed and actually very detrimental to the children. You can't make small tweaks here and there and hope to fix things. There needs to be an abolishment, there needs to be substantial change. And regarding the statistics brought forward by the second speaker, so I respect you immensely as a consultant. However, regarding this debate, I think it's a little bit biased to bring your own research into the topic. So, in your own clinic also, therefore, I would welcome it if you can bring some other unbiased research. And the other thing is, you pointed out a question that I admit was showing very good reasoning power, but the overwhelming evidence, again I'm quoting the national policy document, is that, hold on, the scholarship exam has a large focus on learning and memorization, and it has poor validity in identifying and measuring intelligence. They also pointed out concerns about having the scholarship exam as a relatively early age, where the child's capabilities are not developed. Bear in mind, ladies and gentlemen, our topic for today is the grade 5 scholarship should be abolished. And also you mentioned that if you sit with your son 30 times and read a paper, you would realize that some plants need to be memorized. Sir, we are talking about a 10-year-old child and you want to do a paper 30 times with that child. I don't see how you want to keep on with this practice being a child psychiatrist. And also, you mentioned about whether we need to abolish O-levels and A-levels as well because the stress is very high. I quite agree. We have all been through that. But we are not speaking about a child when it comes to grade 11 or grade 13. Even if the actual presenting numbers to the clinic might be low, the impact on a child's brain on a detrimental and very demanding exam might be is quite inexcusable. And you also spoke about the mature role of parent. The parent should play in regulating the hours the child spends on work. I quite agree with you, but I wonder whether this is feasible. Because now most of you are parents, I suppose, and I think you have put aside your ward work and postgraduate work to make handwork for the child late into the night and doing inexcusable, doing atrocious kinds of homework for the child and doing 20 sums with the child. So the role, the autonomy of the parent really does not play much of a role here. What matters is that there is a system in place, and unless we change the system, we will be in big trouble. Therefore, it is our stance that the grade 5 scholarship exam should definitely be abolished in Sri Lanka.
Thank you, Archini. Next, from the opposing team, Dr. Dinusha Sirisena.
Yeah, thank you. So, an English essayist I like most is G.K. Chesterton. So, he had this quote about Chesterton's fence. So, basically what he said was, if you see a fence on a field, be careful why you remove that, because that fence might be there for something. So, before you abolish the Year 5 scholarship, we have to understand what it has already produced. We have to give its due, because we have to understand over half of the people here most probably would have sat for the scholarship exam and would have successfully completed it, gone to a better school, a well-resourced school, and then got into university. Because research has shown, especially the policy sort of like the institute research they have already discussed about, it has shown that 80% to 90% of students who successfully complete the scholarship exam would get into university. So a significant number of students do get into university who successfully pass the scholarship exam. So we cannot just merely say that it is not of importance. It does have an impact, and we have to understand that. As it was earlier mentioned by Dr. Abhay Singha yesterday, only 2.75% of Sri Lanka are graduates. So if we are to increase the number of graduates who can think critically, because again, remember, we are trying to assess students in their critical thinking, in their logical reasoning. So we have to understand, yes, there are issues in the scholarship exam. We have to amend that. We have to modify the scholarship exam. We agree on that. But we should not abolish it. It has done its duty. It is doing its duty. Because again, we have to remember that this is for selective schools and competitive school entrance. It's not a sort of a free-for-all. We are trying to select the intellectually oriented, sort of educationally gifted students. Yes, we have to cater to the students who are sort of sitting at the back of the class, who are underprivileged. Yes, but if we are trying to address the underprivileged children, we have to give them educational choice. That basically means rather than restricting them to a school in their area, we have to allow them the opportunity to go to a well-resourced school. So if we are trying to get them into the middle class, because education is basically a roadmap for the middle class. It allows the underprivileged children to go to the middle class and higher. Education, access to education can be guaranteed by the scholarship exam. So we have to give its due. And we again say that the scholarship exam should not be abolished. We have to understand that there, as it was mentioned earlier, there are issues in the scholarship exam. We propose that if rather than a mark out of 200, if we can give a ABCD sort of a grading, that would be ideal. And if we are to choose a student depending on their skill to a better school, then we can use a sort of a Z score. Because, I mean, if you talk to a parent, the parents wouldn't understand the meaning of a Z score, but the statisticians and the educationalists can get the gist of it and select the necessary sort of students to go into the specialized, well-resourced schools. And again, if we give a grading like ABC, then that would mean the child can tell his or her parents, the relatives, the neighbors, the next door uncle, that they have received this grade rather than being demeaned because they have received a lesser mark. And as it was mentioned before, the students who get marks above 70 should not be penalized. They should be sort of welcomed into their families rather than being sort of demeaned, saying that they have passed the exam. So there are issues, yes. And again, something that we have to understand is we have to educate the parents. We have to empower the parents about their educational choice, and it is an involuntary exam. It's not a forced or an exam that you have to do. It's a voluntary exam. In 2019, in a circular in March, they have made that exam a voluntary exam. So the parents can decide whether they want to allow the student, allow their child to sit for the scholarship exam. So again, it's not something like forced labor or anything like that. We can empower parents. We have to educate the parents about the issues, related to educational stress. We have to address that. We have to talk with the teachers, as it was mentioned earlier by Ferdy. We have to talk with the principals of the schools. We have to educate the teachers about the correct time where they should sort of do tuition class. Because again, tuition classes is not something that is only seen in Sri Lanka. It's seen in Australia, it's seen in US, it's seen in Singapore, India, China, all over the world. There are tuition classes for selective exams. So we cannot just say that we have to do away with tuition classes are all bad. There are issues in tuition classes and tuition masters which we must address. I completely agree on that. But we have to understand that the scholarship exam should not be abolished because it serves a purpose. It helps the intellectually gifted children who are from underprivileged surrounding, who have the capability to go to a better school, but because of an immutable characteristic like their financial sort of state of their parents or the area where they were brought up in or where they were born in, that should not let that child suffer. If they are intellectually gifted, they should be allowed to go to a better school. They should be celebrated in the fact that they have achieved so much. So, again, what I'm saying is that the scholarship exam should not be abolished because it serves a purpose. It has served a purpose. The number of consultants that we have in Sri Lanka and in Australia as well is mainly because of the scholarship exam. Because the scholarship exam has created those sort of consultants and it has allowed them to pave their path to sort of better sort of places. So, again, what I'm saying is that the scholarship exam should not be abolished. Thank you very much.
That brings to an end the first round of speakers. And now the opposing team captain, Dr. Madhuri Senanayake, will summarize.
Thank you. So, in summary, we have heard some very interesting discussions for and against abolishing the Year 5 scholarship. And I will summarize to you why my team and I are firmly of the belief that the Year 5 scholarship requires amendments, modifications, and not abolishment. I agree there are deficiencies, but if we were to abolish it, would be to throw the baby out with the bathwater. If we were to take a show of hands, a good number of us today, present here today, have sat this exam and have benefited from it. Not merely those who have changed schools as a result of it, but potentially people like myself who were in the happy position of being able to enter national schools based on the geographical location of our homes, and for others based on the fact that their parents were past pupils of these elite schools. But nevertheless, even people like me, I do believe I'm an indirect beneficiary in that what happened, very similar to what our chairperson, Dr. Chamara, mentioned at the beginning, was that this placed me firmly within a milieu of very highly capable, highly academic, and highly motivated students. I dare say I may have done less without the social facilitation that occurred within that environment. So, there are multiple benefits, one being the fact that it aggregates the students who have shown early promise in the situations with settings with the best resources, so that it allows the best possible allocation of very limited resources. Remember, this is why analogous to the grammar schools of the UK, and I imagine there might be something similar in Australia, which I'm less familiar with. Analogous to the grammar schools, they founded the central colleges. These central colleges are in all 25 districts of our country, and these central colleges have better resources than the smaller schools in the district. So this scholarship examination allows students to enter better schools within their own district, or for those students who have qualified and who wish to do so, they may even move further away into national schools. But this is essentially a choice, as my colleague reminded you. It is since 2019 by Gazette, it was accepted that it is no longer compulsory, and the circular has been issued. Multiple examinations of which were non-compulsory have been conducted since. So essentially, it is an individual choice. Yes, when one makes policy, one makes it for a population. And there will be outliers who would potentially not benefit from this, which is why it is no longer compulsory. There are significant changes required to the format in which results are delivered, if you like. As my colleague Dr. Muru mentioned, the pass mark is merely 70 out of 200, and a Z score rather than an aggregate mark. An A, B, C grading for these young children would be more suitable than being given a mark, which when compared with a district level cutoff is taken as a fail, even when, as my colleagues in the other team suggested, is a very high mark. So to prevent that, such alternatives are necessary. This is true. But nevertheless, I have to come back to the fact that this is an examination that has significant benefits for a remarkably resource-poor country, which has nevertheless reached educational standards which are well beyond those of its neighbors within its region. Sri Lanka boasts an education system which has levels of tertiary education, levels of literacy, and levels of education far beyond those of the Southeast Asian region which we are in, not to be forgotten. So I leave it to my colleague, Dr. Ferdy, leading the proposing team, to suggest what suitable alternative they are proposing after this abolishment that they wish for. Thank you.
And now to the lead of the proposing team, Dr. Ferdinand Pereira.
Thank you very much, ladies and gentlemen. Thank you very much for my opposing team to make my job such convenient in this evening. And I have two complaints though. Gosh, I'm seeing a terrible deficiency of literature support for any of your claims, Dinusha, Muru, and Dr. Madri. It's okay. And at the same time, I emphasized, we are talking here about the current existing scholarships exam, not about the proposed amendment. We can do that another day, then you can die another day. Now, you have to be very focused to notice that Dr. Muru has gone into extensive molecular level analysis of his son's question papers. That is remarkable. Come on. So I think rest of our parents will also welcome to do that. And apart from that, it appears that Dr. Muru was trying to build a case upon A-levels and O-levels, but here, of course, that we are discussing about scholarships exam of a brain of a 10-year-old boy or a girl, which are very much prone for the neurobiological threats, as it is elaborated by E.J. Kim in 2015. Prolonged, uncontrollable stress over a significant period of time can lead to neuronal degeneration, suppression of neuronal proliferation, as well as morphological changes. Especially these changes are evident in the hippocampus. So it looks like they are encouraging to have a generation with mood and anxiety disorders. So if our population is going to have more kids with anxiety disorders, who are going to benefit? My God. Oh, right. Now, Dinusha was talking about causation, problems of causation and correlation. He was saying that it's for obtaining MDs. The scholarships is a great advantage, or it's an indicator of a person obtaining an MD. I feel very pity about seeing Dr. Chamar and Dr. Suhashi sitting here. None of them has set for the scholarships. My God, two brightest psychiatrists the country is having. Now, again, Dr. Dinusha was trying to highlight that the scholarships exam is no longer compulsory, but it is now on your choice. But for the record, in IPS study 2019, it was shown 92% of our students has sat because of social pressure, school pressure, parental pressure. I can give any number of reasons. Now, my dear Dinusha, you started your speech beautifully with a metaphor of the fence. You better have the fence at the edge of your garden, not in front of your bedroom, man. The child has to walk, and you have to have a proper height of that fence as well. Right? Now, what else? Dr. Muru was very interested in our financial crisis. It seems that he needs to have more PhDs to resolve the crisis. I think he was thinking of exporting PhDs so we will have more dollars. And so now, first speaker, I respect her, she was asking us alternative. Yes, what are your alternatives? But for the record, here I'm repeating, we are not here for the proposed new amendments, but if you need, yes, we can. We did some research and we gone through the syllabuses of Australia, New Zealand, and Nordic countries about what they are doing with their grade 5 or year 10-year-old students. Look, they are having interesting things. They have included their curriculum about coping with puberty, the skills of managing relationships, rules and responsibilities of teams, finding places of reliable information like hotlines, maps, and world's cultural diversity, democratic values, laws, community activities, and how civic goals can be achieved, outcomes of chance experiments. See, there are a lot of things we can propose. And I might say, Dinusha was trying to explain that you need to have resourceful centers in the center. I will need to remind you that the famous slogan of 1988-1989 resurrection, it was Kolambata Kiri, Gambata Kakiri, what happened? So people were thinking centralizing resources will be a good thing. Then the peripheries, they stood up, killing 60,000 of our young men and women. Then I would like to end my discourse with this remark. Unfortunately, my phone is there. So it is from I'm sorry, I will grab this. Blowing in the Wind from Bob Dylan, 1962. Yes, and how many years must a mountain exist before it is washed to the sea? And how many years can some people exist before they are allowed to be free? And how many times can a man turn his head and pretend that he doesn't see? Each and every year, when the scholarships exam results are out, we are seeing suicides of our 10 years, 11 years old children. So how long we are going to wait and pretend not to see? Thank you very much, ladies and gentlemen.
Thank you very much. We'll give a few minutes for the judges to get their thoughts together and comment. And before that, could we have another round of applause for our wonderful speaker?
Yeah, thank you very much. I think we had a really exciting time. I think we all enjoyed the debate. And I'm not going to say much because I may be biased. So I have asked Dr. Danny Sullivan.
Clever delegation.
To pronounce his verdict. I must say he's done his homework quite a bit. Are you happy to elaborate on that?
Yes, certainly. I
So
polled people at the dinner last night, including a 17-year-old girl who spoke about the experience, so I got a bit of an understanding. As I say, I've been very cleverly delegated this task on the basis that I'm less likely to lose friends by making a judgment. I can tell you that we were tied. That is, we went for two different teams. So we are going to ask the audience to determine. But can I firstly say a few things about the speakers? Firstly, I am assuming you are all friends, but sometimes I thought that the witticisms were superb, and the challenges thrown out to each other's competency or proficiencies was wonderful to behold. I thought there was a great use of literature, of wit, and I thought there was a really interesting sort of challenge, both founded upon neuroscientific principles, psychiatric knowledge, as well as appeals to emotion about the welfare of children. So on that basis, I think that both teams deserve a fantastic round of applause for their efforts. And we're now going to ask the audience, through a show of hands, to determine, have we got anyone to count, do you think? Perhaps the moderator? Okay. A show of hands to determine whether the proposing team or the opposition deserves to have won this debate. So firstly, can I ask if you believe that the proposing team won the debate, to raise your hand in the air? Keep your hands up. The proposing team. Okay, thank you. And now those who believe that the opposing team won the debate, put your hand up.
Slightly less, I think.
I think slightly less. So on that basis, I think we can award the debate to the proposing team. Congratulations. And then, of course, the next challenge is to work out what to do to replace the Grade 5 scholarship exam. So this is how public policy should be made. A show of hands by psychiatrists.
So now Dr. Daldy Sullivan will be giving away the certificates to the winning team, Dr. Ferdinand Pereira, Dr. Suhashini Ratnatunga, and Dr. Achini Samaranayaka. And in second place, the opposing team, Dr. Madhuri Senanayaka. Dr. Miyuru Chandradasa, and Dr. Dinusha Sirisena.
So, ladies and gentlemen, now we are coming to the end of our academic sessions. It's time to give away the awards and prizes for the winners of our competitions. And it will be given away by our dear President of the college, Dr. Gihan Abewardena. So, if you would please come to the stage. So, first of all, we will be giving the awards on the painting competition. Yes. So on the painting competition in the category of nature and animals, the third place goes to Reflect from Dr. Indu Maheshika. And in second place, Placidity from Dr. N.E. Hendavitharan. And in the first place goes to Miraculous Love by Dr. N.E. Hendavitharana. And next, on the category of people, the third place is awarded to The Summer of 1899 by Dr. Upeka Vimalasiri. Isri Upeka Vimalasiri, Dr. Isri Upeka Vimalasiri, sorry. And the second place goes to Lost by Dr. Indu Maheshika. And the first place in the category of people goes to Summer Glow from Dr. Chandima Vikramasinghe.
In the abstract category, the third place goes to The Golden Clock in an Empty Room by Dr. Nipuna Ranavira. Second place goes to Medusa F20 by also Dr. Nipuna Ranavira. First place goes to The Cradle, submitted by Dr. Diniti Kodikara Achi. And in the Still Life category, the third place goes to Freshness, submitted by Dr. I.P. Sandarenu, Inoka Sandarenu. Second place also to Dr. Inoka Sandarenu. And the first place, The Difference between The Difference by Dr. Inoka Sandarenu. Next, we move on to the photography category. So, for the wildlife category, the third place goes to Take Off by Dr. Shane Jayasundara. Second place goes to A Leopard That Won't Bite by Dr. Malsha De Silva. And first place goes to Graceful, submitted by Dr. Laochana Samarasinghe. We must mention that the judges have commented that the first place was awarded due to the photograph's excellent composition, lighting, and sharpness. And in the street category, the third place goes to Doorways by Professor Thilni Rajapaksha. Second place also goes to Man at Work by Professor Thilni Rajapaksha. And first place, ladies and gentlemen, for its excellent composition, lighting, and form for Shadows by Professor Thilni Rajapaksha.
Ladies and gentlemen, in the category of landscapes, third place goes to Suspended Animation by Dr. Malsha De Silva. And the second place goes to Impermanence by Professor Thilini Rajapaksha. And the first place in the category of landscapes goes to A Rest Before the New Dawn by Dr. Lochana Samanasinghe. And we must mention the judges have complimented it on its excellent composition and its aesthetic appeal. Next up, on the category of mobile photography, the third place goes to The Yellow Dancing Flower by Dr. Sanoja Iroshani Pathigoda. And the second place goes to Wisdom by Dr. W.W.I.P. Sandarenu. And the first place goes to, for its well-captured moment, Senseless by Dr. Mithila Kulatunga. And I'm sure you all are waiting to know who the winners are in the poster competitions. Third place in the poster presentations, validation of Sinhalese version of the problematic media use, short form for the assessment of screen addiction among children and adolescents by Dr. Anuradha Baminiwatta and Dr. Thilini Nanayakara, Dr. Angshu Fernando and Dr. Sarna Vijayatunga. The second place in the poster presentations goes to the poster, Does Marriage Lessen the Risks of Stroke and Improve Post-Stroke Functioning Level and Survival Rate by Dr. M.L. Harshini, I. Premaratna, Dr. D. Edrivira, Dr. U.K. Ranavaka, Dr. A. R. Vikramasinghe and Dr. A. Hapugama. The first place for poster presentations in annual academic sessions goes to the poster Cultural Adaptations and Validation of the Brief Resilience Scale in Sinhala and Tamil Language by Dr. Anuradha Baminiwatta, Dr. W.T.R. Fernando, Dr. T. Gamanathan, Dr. A.S. Fatima, Dr. W.A.R. Sasala, Dr. L.A. Kuruparachi, Dr. A.R. Vikramasinghe and Dr. A. Hapugama. Hapangam, sorry.
Now we move on to the awards for the oral presentations. In third place, validation of a Tamil version of the Copenhagen Burnout Inventory. Dr. W.K.T.R. Fernando, Dr. A. Baminiwatta, Dr. T. Gadamanathan, Dr. A.S. Fatima Jata, Dr. H.M.N. Thisera, Dr. K.L.A. Kuruparachi, Dr. A.R. Vikramasinghe, and Dr. A. Hapangama. Second place goes to a randomized controlled trial of a mindfulness-based online intervention to reduce stress and improve mental well-being among healthcare workers during the COVID-19 pandemic. Dr. A. Baminiwatta, Dr. R. Fernando, Dr. I. Solangarachi, Dr. T. Abbe Bandara Herath, Dr. A. R. Vikramasinghe, and Dr. A. Hapangama. And ladies and gentlemen, the Peter and Mabel Curray Gold Medal for the best oral presentation is awarded to the validation of the Sinhalese version of the Cornell scale for depression in dementia in Sri Lanka. submitted by Dr. G.R. Sirivardhana, Dr. K. Ranasinghe.
Thank you, sir, for giving away the presents. So with that, we conclude the award ceremony. We cordially invite our Secretary of the Sri Lanka College of Psychiatrists, Dr. Chamra Vijayasinghe, to deliver the vote of thanks.
May I also take the opportunity to remind you that the AGM will be held at the conference hall from 5:10 p.m. onwards. Thank you.
Thank you very much, and yeah, that's about it.